for having me. Looking forward to giving this talk. We're talking about supportive and palliative care, and when I was talking to Mary and other people at the ALS Association about it earlier, I think that, in a nutshell, what palliative care is it's all about really living as well as possible for as long as possible. To really understand the goals of what palliative care is, and also I think importantly to understand what palliative care is not. And both patients and doctors, I think, have some ideas about palliative care that actually interfere with the goals of palliative care. That a lot of times people are waiting for the quote right time to talk about hospice or to talk about palliative care, and what that usually means is that it ends up happening in the ICU after there's a tube down your throat and after people have done things to you that you didn't want them to do to you. So I think it's really important to understand both of those sides of it. We'll talk about really some specific issues in palliative care that both patients and families with ALS face. And that's one of the core principles of palliative care, is that an illness like ALS doesn't just affect one person. It affects partnership, it affects a family, it can affect a whole community. And so that's really a key principle of palliative care. We'll talk about hospice and what hospice is, when hospice starts, what hospice can provide. And I know there's been a lot of interest in the Medical Aid in Dying Act. And so we'll talk about what that is, how we approach it in our clinic, and answer questions about that. And then I'll describe our clinic and some of the work that we're doing as we move forward. And since it's a relatively small crowd, we can kind of take questions as we go. If you have questions that you're embarrassed to ask or would rather not ask, you can write them down on a piece of paper, and I'll try to get to those at the end of the talk. So this is a quote from the American Academy of Neurology. So many patients with neurologic disease die after long illnesses during which a neurologist acts as the principal or consulting physician. Therefore, it's imperative that neurologists understand and learn to apply the principles of palliative medicine. And I'm just kind of asking people in the group, what year do you think this statement came out? Anyone wants to throw out a guess?
1960.
1960? It's a good guess? Yeah.
95.
95? Oh, that's actually a really good guess. Correct answer is actually 1996. If I had a candy, I'd throw it to you for a prize. But yes, in 1996, this is what else was happening in 1996. We had the Bulls and the Spice Girls and Jim Carrey. But since that statement came out, there's been almost no training in palliative care until really recently. Our program is actually one of the leaders in neuropalliative care. And actually this last year was the first year that we actually had a block of palliative care education for our residents. So we're really trying to change that. But as time has gone on, palliative care actually started in the late 1960s in the United Kingdom. Dame Cicely Saunders started the hospice movement there, and then it moved to Yale on the East Coast. And it's been for a long time really tied to hospice, and it's been tied to cancer. And it's really over the last 10 years that we've kind of been breaking that cycle and looking at it for heart failure, for lung disease, and now more recently for neurologic conditions, including ALS, dementia, stroke, and Parkinson's disease. And so I wanted to talk a little bit about how I got into palliative care, because it wasn't really something that I had planned to do with my career. So the first case, I had did my residency, medical school, everything here at the University of Colorado. Went to Florida for fellowship in behavioral neurology and movement disorders, which is studying dementia and Parkinson's and things like that. And then I came back. And so this was a patient who really stuck with me. She was a 54-year-old woman who was diagnosed with Parkinson's disease. After 2 to 3 years, her medications weren't really working. She was wheelchair bound and ataxic, meaning that she had problems with her balance. And so since I went to fellowship and I was really smart now and could make these diagnoses, I changed her diagnosis to multiple systems atrophy. So I gave her the right diagnosis, we got rid of her medications, I got her to stop driving. And that was kind of all I had learned during fellowship, that I could make the smart diagnosis. And I had seen them for a while, and I actually remember one of our visits where the husband had brought his wife to a medical hypnotist to work on these positive affirmations. And so every morning she was supposed to look in the mirror and say, I feel myself getting better, I feel myself getting stronger. And I asked her how she felt after these positive affirmations, and her answer was she felt like shit. And we'll get back to that, but I think one of the things that's really key, and then what we really hope to do with palliative care, is kind of making a distinction between real hope and false hope, and really working with people where they're at. And we can talk more about how we can work with real hope. They sought several second opinions, they sought experimental treatments, and after a few visits they stopped seeing me because there was really nothing more that I could do. And that bothered me a lot. And so some of the lessons I took away from that, and this is certainly true with ALS, is that people with neurodegenerative illnesses like ALS, like multiple systems atrophy, like Parkinson's, like Alzheimer's, really need more than our current system provides. That there's a lot of gaps in care in our system. That myself and other neurologists really aren't well prepared to help patients and families on this journey. And lastly, and we'll get back to this too, is that people can be upset for reasons other than depression. So in our clinic, part of the reason actually I started the clinic was that I saw people who I thought were sad and frustrated and worried for good reasons. But all I was taught in medical school was how to diagnose people with depression and put them on Prozac. And that's not always the right answer. And so, so we need to have kind of a broader palette of what kind of difficult emotions we see and how we work with them. The second patient who I saw that really had a big influence on me, she was a 21-year-old woman with a 10-year history of juvenile Huntington's disease. And I had actually seen her sister as well, and actually put her sister earlier that year in hospice, and her sister had passed away. They got Huntington's at age, I think, 9 and 11. And she had a whole bunch of symptoms, including problems with sleeping. And over the last year, she had several friends and family members who died, including her younger sister. And her main problem was why she couldn't sleep. And when I asked her why she couldn't sleep, she said, "I'm afraid of dying in my sleep." And that really kind of made a connection for me. Because I think up until that point, I had always seen kind of spirituality and spiritual care as something that chaplains did, as something that was kind of poof or whatever, but this is a spiritual problem. And we'll talk about this more too, but with ALS and with neurologic diseases, as I'm sure everyone in this room knows, they really present a lot of existential challenges. They challenge your identity, they challenge your connections to people, they challenge your sense of who you are, your sense of a future, potentially your relationship with God. And so, as I was working with her, this was also why she wasn't taking sleeping pills, because she thought it would make her more likely to die. And a few months prior, actually, I'd spent some time at a Zen monastery because these kinds of questions and things were bothering me, and I was working with a monk there who volunteered at hospice. And I thought, that's really scary. I'm scared to work in hospice, and I'm a doctor, and I could hide behind my white coat, but he's just there working with people who are dying. And I asked him, how he did it and what he could offer, and he said the most important thing was to just be there, to be present, to be open, and to not try to make this false line that I'm somebody who's not dying and you're somebody who's dying. And to accept, that your own role with dying, with suffering, with old age and sickness, and that really changed things for me. And so when I met this young girl, I was able to have this conversation with her. And just by having this conversation, I think it was the first time she admitted this fear in front of her mother and her family, and by putting it out there, she actually began to sleep better almost instantly, because now it was no longer something that she was holding in and trying to keep to herself. And so that was, part of my invocation to palliative care. And so, the fear of death, fear of the future, as our chaplain puts it, when we ask people about fear of death, we ask, are you afraid of what happens before dying or after you're dead? And they're both, legitimate fears. And there's different ways to work with them. But ultimately, a lot of it comes down to spiritual issues. And I realized at that time that just being present, that being open, by working in a partnership, by empowering patients, by learning from patients, from their grace and their strength and their intelligence, that we can get to a much better place than with me being the only expert in the room. Another thing that I realized from this case was that we really needed a team, that we needed a chaplain on our team, that we needed a social worker, that we needed a nurse, and that we also needed to set up a clinic where this was really our focus and our intention. That if our focus and our intention is muscle cramps or EMG or other things like that, we're not going to have the energy and the time to really help people with these problems. So that's how we got started, and that was in 2013. And since that time, we've really grown. We have clinics now 5 days a week. We have a clinic in the cancer center. There's a new faculty member who's joining us who's going to start up a dedicated ALS palliative care program. So we're really, I think, doing good and exciting work. So what is palliative care? Just by way of hands, how many people have heard of palliative care? So it looks like almost everybody. And this may be a more sophisticated audience than some. I think a lot of people, when they think about palliative care, they have a picture like this in their head, which is calling Dr. Death, it's death panels, things like that, and I really want to disabuse people of that notion. So palliative care, first of all, I want to make clear, includes hospice, but it's not the same as hospice. Hospice is palliative care for the end of life, for the last 6 months of life. The palliative care, as we talk about, really can start at the time of diagnosis. And for an illness like ALS, I think it should start at the time of diagnosis, because that's really a crisis time for patients and families. Palliative care is not euthanasia or death squads. And when we talk about medical aid in dying, actually the palliative care community is split on whether they should even support medical aid in dying. Our clinic does, not all clinics do. Some people in palliative care feel that medical aid in dying actually will take away resources from good palliative care because we're not doing a good job in supporting people with their palliative care needs. Palliative care is not giving up on patients. And I think some of that comes from the language that we use, particularly around cancer, about doing everything or doing nothing. In our clinic, we do a lot of things for people, but we're very aggressive about keeping them comfortable. We're aggressive about keeping them at home. So we're not giving up on patients. We actually spend 2.5 hours with patients in our first visit, so we spend a lot of time with people. It's just not putting that energy towards just pure survival or curing their illness. It's not for people who are imminently dying. Like I said, it could be at any point along the course of the illness. It's not just for cancer. And the last thing that's important, and this is part of our work that we're doing, is it's not just for palliative care specialists. So palliative care, what it is it's an approach to the care of patients with serious illnesses. And the goal of palliative care is to try to improve the quality of life of patients and their families. And we've really expanded our sense of palliative care. So part of that is to relieve different sources of suffering. And that could include difficult to control symptoms like pain, like breathlessness, like fatigue. And it also includes looking for opportunities for joy. And we've kind of made that a formal part of our clinic as well. That we address psychological, social, and spiritual issues. So these are not problems. These are not things that we don't expect along this journey. And we also, I think really importantly, we affirm and support life while addressing death as a normal and expected process. And under the affirming and supporting life, some of the things that we've done is we've actually gotten some quadriplegic people hooked up with skydiving because that was something that they wanted to do. We've had RVs that we've modified so that people could continue to travel. I think one of the most important things that we do is have honest and frank discussions about what the future is going to hold, so that people can make plans. Actually, just this last Friday, I saw a patient with ALS, and the two most important things for her was one was spending more time with her family in California, and the second was seeing Kenny Loggins, who's going to be here on August 11th. So by having this honest discussion, and I think her neurologist, and I don't know if other people have had this experience, oftentimes I think try to sugarcoat things, and they're sometimes vague, and they're like, well, there's a lot of possibilities here, but I think if you don't have really solid, concrete information and know what the best case and the worst case and the expected is, it's hard for you to make life plans that you need to make. And so we've definitely had a lot of people who have, really gotten serious about spending time with their family, about taking trips, about doing other things like that. And that's part of why we think that palliative care should really start as soon as possible, so that people have the opportunity to do those things that are most important to them. As far as addressing death as a normal and expected process, I'm glad the slides work. So this is an older slide. This is from 1996, but the trend has actually still continued. I don't know if Donald Trump will be able to change this figure, but so far no one else has. But and I put this up for two reasons. One is, I think the U.S. healthcare system is like one of the few healthcare systems in the world that acts as if death is optional. And clearly death is not optional. We do not have a choice of whether or not we die. We don't even really have that much of a choice of when we die. And I'll present some data later that people in hospice actually can live longer than people not in hospice. So the aggressive care that we're providing at the end of life doesn't influence necessarily whether we die, it doesn't influence when we die, it does influence how we die. And just by a show of hands, how many people here want to die in a hospital? No? Okay, in the ICU on a machine? No? Okay. That's pretty typical. I mean, most people do not want to die in a hospital, but when we don't have these conversations and when we're not prepared for it, people do die in hospitals. And people with ALS, with Parkinson's, Alzheimer's are more likely to die in a hospital than people without these illnesses. And so it's really imperative that we do our best to make sure that if your goal is that you want to die at home with your family around you, that we do our best and we help prepare things for that so that you have that opportunity. One of the things that's actually different about my practice than some other neurologists is that I'd say every week I get emails from or calls from 2 or 3 patients who have died. Before doing palliative care, I'd say maybe it was like 1 patient a year who died. And it wasn't because they didn't die, it was because I was no longer connected with them. We can use it with curative treatments, that we have people in clinical trials who are getting palliative care. Some of our Parkinson's patients are getting DBS and getting palliative care. People can get chemotherapy and palliative care. So it doesn't have to be an either-or thing. Your goals of care could be aggressive care. It could be that you want a mechanical ventilation. It could be that you want a PEG tube. That doesn't mean that you can't also benefit from palliative care to try to keep you comfortable and to support your caregiver. So I want to really make clear that it's not this either-or kind of thing, that you can have the best of both worlds. It can be appropriate at any point along the illness, including the time of diagnosis. It definitely benefits from a team, and there's a lot of places that we contact people. So we have an outpatient clinic, but there's inpatient palliative care services, and then I'll talk later about hospice, which most often is home hospice, not being in a physical hospice. It talks about a 3-legged stool for thinking about palliative care. And so one leg of the stool, and then we kind of think about palliative care as a system as opposed to a specialty. And if we think about palliative care as a system, one of those legs is community organizations like the ALS Association that has support groups and that has other resources for people. One of those legs is your primary neurologist or primary care providers. And one of the things that we're doing, and we're doing some studies which I'll talk about later, is trying to teach neurologists and teach primary care providers to provide better palliative care to their patients. To be able to do a better job with talking about diagnoses, giving bad news, helping people to plan for the future. And then we have specialized teams like our team at the university to really provide extra services and hospice and things like that for people and families who are really struggling with things. These are the core things that we're teaching neurologists, and actually I'm giving a 10-hour class for neurologists this coming Saturday, and we're teaching neurologists about how to do a better job of communicating at the time of diagnosis, making sure that people have quick and rapid follow-up after they get given news like they have ALS. I don't know how many people here that getting that diagnosis was kind of traumatic. About symptom assessment and management, so doing a better job, particularly around managing pain, which can be a big issue for people with ALS, managing breathlessness, working with fatigue, working with sleep, anxiety and depression, advanced care planning, which is getting paperwork and documents in order for the future, doing a better job with caregiver assessment. I think a lot of physicians, and myself included before doing palliative care, just didn't even want to talk to the caregiver. Because if they told me that something was bad, I wouldn't even know what to do with that. So helping people with better caregiver support, and then also knowing when the limits of their knowledge is and when they should refer for other palliative care services. So if you think about a diagnosis like ALS, there's a number of points along the journey where palliative care can be needed, starting with the time of diagnosis. But that's a time where both patients and families, I think, need a lot of extra support. Are really confused, need some help with planning for the future depending on their age. We talk about disability and things like that. And oftentimes, and this is what I mean by gaps in the system, are kind of left on their own to try to figure it out, or they go to the ALS Association or other people, but they're not getting their help from their doctors. That as the illness sets in, and particularly as from the early disease, that you get that sinking feeling that I'm going to wake up with this illness every day for the rest of my life. Once that initial diagnosis comes in, there's definitely a need for spiritual support services. How do we build resilience? How do we cope with this illness? How do we maintain hope and maintain connection and maintain faith? In the face of an illness that's so devastating that we don't have a cure for right now. As things progress, trying to make priorities in terms of what's important in our life and what are the things that we want to make sure we're able to do, and then for your healthcare team to help make sure that those things are possible. And as we get closer to end of life, to get things in place like hospice so that you are able to die at home, you are able to get the support that you and your family need towards the end, and then also bereavement services for after death. If we think about palliative care, It's not a straight line that starts at 0 and goes to 100, but that over the course of illness, it's more like a roller coaster, and I'm sure you've all experienced this, where there's times where things are more stressful and you need more support, and then things can be relatively calm. And the first spike, actually, that I put there on purpose is the time of diagnosis, which is a time where I think people really need a lot of extra help and support. When I talk to doctors about palliative care, I usually get one of two things. One is that that I don't want to talk to my patients about this, it's too scary for me. Another is that, we already are doing it, we don't need your help. And it's this idea that, we can't cure these patients anyway, so therefore we must be doing palliative care. And if we had the slide up here, it says, ask your doctor if taking a pill to solve all your problems is right for you. It's the comment. So there's key differences between chronic care, which is I think the predominant model for ALS right now, in palliative care. So in chronic care and in our current healthcare system, our main goal is to preserve function. It's to prolong life. The focus is really directly on the patient. We're focused on medical and psychiatric symptoms, and we kind of bring in team members as we need to. Whereas with palliative care, the primary goal is to relieve suffering, and I would add to that to find opportunities for joy. That we plan for death and decline is kind of normal and expected process, that the focus is not just on the patient but also their family. That in addition to these medical symptoms, we also focus on physical, psychosocial, and spiritual issues. And then we almost always use a team just because there's so many different skills involved with this. So for palliative care in ALS, Lou Gehrig's disease, that's a nice picture of Lou Gehrig with Babe Ruth. So these are some, I think, the big palliative care issues that come up. And so one, and I saw a lot of head nodding, is around diagnosis and also around prognosis. And the kind of big questions that people have is, how long do I have and how well will I be able to live? And what's kind of the balance of those two things? To really clarify what goals of care are, and I'll talk about what we mean by goals of care. Advanced care planning, treating medical symptoms, helping caregivers be supported, difficult emotions, spiritual and existential well-being, and then end-of-life care. So the top part of the slide is a man pointing his finger at a dog and he's saying, okay, Ginger, I've had it, you stay out of the garbage, understand, Ginger, stay out of the garbage. And on the bottom is what the dog hears, which is blah, blah, Ginger, blah, 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 Ginger, blah, 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 blah. And I think the first time you get a diagnosis like ALS, you probably just hear 3 words that whole visit. And so one of the key things with this is, as I tell people, and I do this myself, is not to spend too much time that first visit, but to make sure that there's a really quick follow-up visit within a few weeks or a month, so that people have a chance to process that and answer their questions. No matter how skilled you are with communication, people are just not going to be able to process that much information. And so we spend a lot of time talking about how to give bad news with compassion. And then following that up about prognosis is the first thing that we do is we want to ask the patients how much they want to know. I think a lot of doctors make the assumption that people don't want to hear bad news. I would say 90% of the time that's not true, that people really want to know, and in fact they have a strong suspicion about how things are going. And more often than not, they're right. When I break the bad news and tell people how much time they have left and things like that, it's pretty rare that they're surprised. More often than not, they're relieved because now they know what they're dealing with. It's been confirmed by somebody else, and they can start having a real game plan. And ask people, what are their perceptions of how things are going? When we talk about prognosis, I think the 2 big questions is how long and how well. And in ALS, there are some trade-offs that can be made. With some people with ALS, mechanical ventilation and trachs can prolong life. So that is a situation where people do have a choice, and they can make a trade-off between how long they're going to live and how well they're going to live, and what's important to them in living longer. The majority of people with ALS choose not to do mechanical ventilation because for a lot of people, maintaining independence and being able to do things for themselves is more important. But there's other people who choose the opposite, and both can really work well. It's really making sure that we understand people and support their goals. I don't know if people, I'm trying to remember the name of the movie about Gleason with ALS. It's called Gleason. Yeah, I don't know if other people have seen the movie Gleason.
Yes.
Yeah, the documentary Gleason. It's a real moving film about a gentleman with ALS who was on the New Orleans Saints. who made the decision to get a feeding tube and to do mechanical ventilation. And for him, that was absolutely the right decision. And there's a lot of patients who make the decision not to do those things, and that can be the right decision as well. And so there's not a right or wrong answer about this. And that kind of ties into our discussion of goals of care. Is my job is really to try to get to know you and your values as well as possible so that we can make a decision together. And what I see happen a lot in ALS clinics and other things is that the nutritionist and the respiratory therapist try to make or force a decision on you based on the idea that the only goal worth having is survival and safety. And that's not the only goal worth having. When we talk about the future too, I mention to people that I don't have a crystal ball, that I can't see the future, but what I can help people with is to provide them with a roadmap. And I think the roadmap analogy works pretty well for people. We kind of talked about what region of ALS we're in. We talked about the best case, the worst case, and kind of my best guess. And I think importantly we talked about what are the signs that we might come into that suggest that things are changing. So for instance, if I'm seeing somebody with ALS and things are more advanced, I might let them know that if we start seeing problems with a lot of weight loss, a lot more problems with swallowing or whatever, that might be a time that we're going to think about hospice. And so by having those signs, it really helps the patient and the family know what to look for, because a lot of times they're scared and they don't know what to look for and they don't know what to worry about. And so I really help share with them what my thought process, and I think that idea of having a roadmap and having a shared roadmap is really helpful for people. So for goals of care, so this actually is a picture of an 87-year-old woman with ALS, who one of her bucket list things was to go skydiving. And there was a really great article in the New York Times about goals of care, and a very quick and easy, and I think a fun way to understand people's goals of care is if they have a bucket list to see what's on the bucket list. Because those are the things that we really want to prioritize. And so if your bucket list is about spending time with your family in California, it's about seeing Kenny Loggins, it's about skydiving, it's about traveling, it's about spending more time with your grandchildren, that needs to be the number one goal. And then we figure out what we need to do to make those things happen. Related to the goals of care is looking for opportunities for joy. And so we've made that really a core part of our clinic. And kind of some of the things I would put under the opportunities for joy is one is meaning. And these are all kind of ways that we build resilience and that we are able to work with real hope. But things that people can find meaningful is the way they face their illness, the way they face the dying process, whether and how they share that with their family. Can be very meaningful. Taking part in medical research, teaching medical students, being a volunteer. Actually, that same patient who I was talking about, is still spending, going to the Humane Society and working with older adults, for 10 hours a week, because that's what's meaningful to her. Connection is a big one. So connecting with family. You use the word love in clinic, and you use the word love here. But where do we find love in our life? And then also just simple pleasures, and that could be music, that could be catching a sunrise, that could be touch, it could be holding hands, and trying to make each day as meaningful and as joyful as possible. And really trying to focus, ALS is not something I would want to wish on anybody, but ALS and Parkinson's, Alzheimer's sometimes becomes this thing that makes, the last 2 years of somebody's life, are the best 2 years of their life. And it's because, they've heard the message that, now's the time they have to do things. And it's kind of one of the gifts that I get in working in this area is just being reminded to not put things off for, next week or next year or whatever, to really try to do what I can today. For planning for the future, it's closer than we think. And again, I think physicians are bad at this, patients are bad at this too, is waiting for the right time to get paperwork and other things in order. And so we'll spend a little bit of time on this. So advanced care planning, we'll go through. Do people are familiar with the terms power of attorney? So power of attorney, your medical durable power of attorney, that's probably the most important thing that you get in place. So that is putting in writing who you would want to make medical decisions for you in the event that you can't, that you're unable to communicate those. And people may not know this, but the state of Colorado is an all-interested party state. And that means that if you're in the hospital, it doesn't automatically mean that your husband or your parent or someone else is going to make decisions. if you don't have it in writing, the doctors taking care of you are obligated to contact all potentially interested parties, including potentially your sister who you hate and haven't talked to for 5 years. And you know, and we see this actually on a weekly basis, that there are family members who you know, really screw things up for the patient, and who cause problems, who prolong things, who cause unnecessary suffering. So really important to get that in place and to get that in writing. And I think the more important reason is to, you know, have who you want to make decisions, but also have who you don't want to make decisions not on that list. Advanced directives, are people familiar with advanced directives or living well? The most important piece of paper with that, there's something called the MOST form, which is medical orders to sustain treatments, and it's a bright green piece of paper that you put on your refrigerator. And the 3 questions that are asked on it is, one is if you're dead. So if you're not breathing, your heart's not beating, do you want resuscitation? And when I talk to people about this, I make sure that they know, because actually lawyers don't know this either, is that CPR on television, which is how most people know about CPR, is very different than CPR in the real world. And this has actually been studied that a group of medical scientists that watched 6,000 hours of television, and they found that on the 6,000 hours of television, anyone want to guess how many people survive CPR on television? Almost all, 90%. You know, and a good percentage of those people, you know, they go back to fight crime, they have psychic powers. You know, it seems pretty cool. In the real world, what percentage of people get back to their prior level of independence? Yeah, less than 10%. So in the real world, unless you're a kid who falls into a frozen lake in front of a fire department, your chances of leaving the hospital are less than 50%. And your chances of getting back to your prior level of independence are less than 10%. And so I think people need to know that so that they can make an informed choice about what they want. Because a lot of times I'll see the paperwork that they fill out with lawyers, and it's 15 pages long and it doesn't make sense. It says that they want CPR but they never want to be on a machine. Well, you're not going to have CPR and not wake up in the ICU. And so it's really important that you do this with the doctor and with the healthcare professional. Yeah.
The other thing they never mentioned is if you do survive CPR, you hurt immensely.
Yeah.
Ribs smashed, your sternum smashed.
Yeah, so this gentleman was saying, which is important and something worth pointing out, is that unlike on television, that if you survive CPR, you don't feel so good. That you might have broken ribs, you have a sore chest, you haven't had a tube down your throat. You know, there's a good chance that you may have brain damage from lack of oxygen to the brain. And so it's not an easy thing to go through. And so it's really, you know, it's really more a question about, you know, what kind of chances you would rather take. Are you somebody who, if there's a 10% chance that I'll be able to spend more time with my family and watch cartoons, I want to take it? Or are you somebody where if there's a 90% chance that I'm going to be more dependent on people than I already am, you know, don't sign me up for that. I've already had enough of it. The second thing that they ask is about what kind of treatments you would want, say, and I always use the example of a pneumonia. So if you have a pneumonia, are you somebody who would not want to go to the hospital, just get antibiotics at home? Would you be okay with getting IV fluids and IV antibiotics? Or are you somebody who's okay going to the hospital and even being on a breathing machine? And then the last thing it talks about is feeding tubes and whether you want that long-term or short-term. And again, there's not right or wrong answers about it, but it's good to have them in writing. And again, it's good to have these things done early because when you wait for the right time, and we've actually documented this, that in our hospital, we published this, that when people get a palliative care consult with a neurologic illness, at the time of the consultation, 70% of those people can no longer communicate. And so if you're not doing this in advance while you can still talk for yourself, chances are you won't get that chance. And then it makes it's actually a real gift to your family to be able to put this in writing so that they really know what you would want. And I put down a couple of things down here. There's something called the Conversation Project. There's also a really neat tool called Go Wish Cards that you can do with your family so that they can really understand what your values are and so that they can make proper decisions on your behalf. And actually when I talk about power of attorney and I talk about that role for people, I don't like the word decision maker. I usually tell people to be that person's voice. And so if you can really understand your loved one and what they want, then you can be their voice, and it's not about making a decision for them, it's about speaking for them as if they were in the room with us. And we can talk a little bit about artificial nutrition or feeding tubes. You know, those can be helpful in certain situations. They can help maintain nutrition. They can help maintain hydration. They don't prevent aspiration. And there's kind of mixed data on whether they prolong life, but in people with bulbar ALS, they may. And same thing with mechanical assisted ventilation and trachs. Those can certainly prolong life in certain people with respiratory distress. And the data is mixed on whether or not it improves quality of life. And so again, it's something that's really important to go into it with your eyes open. And for some people, it's the right decision. For some people, it's something that they just did what their doctors told them to do, and then they and their family end up being in this position of trying to decide what to do now. So that can be kind of difficult. And even in that situation, it's still important to have advanced care plans to figure out, when would staying alive not be meaningful anymore. Because people can end in a locked-in state. They can end up with dementia, other things like that. And so again, it's important to have these open and upfront conversations. For medical symptoms, a list of things that we often deal with include pain, fatigue, breathlessness, constipation, excess saliva or drooling, depression, anxiety, insomnia. Those are all things that we work with a lot in our clinic. One thing also to mention is that these slides are going to be online. So you'll have a chance to look at them, and you can make notes and stuff online later. One thing that I get a lot of questions about is cannabis. And I've given plenty of talks about cannabis. So just kind of briefly talking about cannabis is there are a number, there's actually now over 100 of psychoactive chemicals in cannabis. And so the differences between indica and sativa and hemp, which is very low THC products, are pretty big. And so you definitely want to make sure that you're using the right product. I have a lot of patients who come in who have taken something that they got from their son, and they had either a very good or very bad experience, and then they either want to keep using it or never use it again. And so it's important to know that there's a lot of variability there. There's no conclusive evidence right now supporting the use of cannabis for any aspect of ALS, but anecdotal evidence suggests that it can definitely help with pain. And with pain, some of the options that I often use are creams that have THC in them, but it seems that THC can be really important and helpful for pain and for muscle spasms. It can definitely help with sleep, with anxiety, with appetite, and with nausea. And so those are things where I'll use cannabis, and oftentimes we'll have less side effects with cannabis products than we do with benzodiazepines and opiates and other more typical medications that we often use. Some of the potential side effects can include, not surprisingly, confusion. And there's a reason why they call it dope. It can cause low blood pressure, it can be associated with falls. It can cause breathing issues if smoked, and so again, we want to be careful about how you use it, but it can definitely be helpful. For caregivers, that caregivers are at increased risk for chronic illnesses, and depending on the study, can have up to a 60% increased mortality rate to people who are not caregivers. Part of that is through high blood pressure, cardiac, loss of sleep, depression. So there's a lot of things that can come up with a caregiver who's overwhelmed. And again, part of our goal for doing early palliative care is to try to prevent caregivers from being overwhelmed and distressed. Once people are burned out, it's very hard to unburn them out. And that's why we like to try to get involved early with people. These are some of the questions that I will often ask caregivers when I see them. Are you feeling overwhelmed? Ask them about their health. Do they feel isolated? Do they have time to take care of themselves? So those are kind of some of the things to think about for caregivers. And if your answer to those is yes, I am feeling overwhelmed, my health is awful, I don't have time to take care of myself, I'm feeling isolated, then better to get help earlier than to burn out, and then that causes problems for everybody. So this slide is just another great joke slide. It says on the top, Prozac is not always the answer, and there's a psychiatrist and a patient. So the patient is saying, could we up the dosage, I still have feelings. And I feel like this is kind of the medical system, and also I think maybe the U.S. system, just Americans in general's answer to feelings. Whether it be Prozac or alcohol or whatever that we all want to numb our feelings. And I think it's important to realize that not all being upset is depression. So there's definitely depression that can come along, but along a journey like this, and one of the things that I actually teach physicians is a process called NURSE for helping people with difficult emotions. And the first step at the N in NURSE is naming. And so for a lot of people, understanding that there's a difference between depression and grief, and where grief is loss associated with either your current self or your future self, can be very helpful. It's not uncommon that people get angry along this journey, that they may feel guilty, both caregivers and patients along this journey. People may feel frustrated, they may feel demoralized, they may have fears, they may have worries, and that's different than anxiety disorders. And so our job with NERS is that we want to name this emotion, that we want to try to understand it, that we want to respond to it in a compassionate way, explore it. And there's also a quote that I like, and I give in my talk to physicians, that all problems are psychological, all solutions are spiritual. And so as these difficult emotions come up, I find that sometimes the best way to work with them is from a spiritual point of view. And that doesn't necessarily mean religious, but spiritual in terms of where do you find meaning in your life, where do you find peace in your life, where do you find connection and love in your life, and building from those places of strength and grace to work with these very hard things like grief and sadness and anger and frustration. And we want to make sure that people have room to have these negative emotions, that we don't want to, the message is not that, we need to up the dosage or we need to do whatever until you shut up, which I think is, I think a lot of people, is the message that people get consciously or unconsciously, not just from physicians, but also from their family, from society, that you have space for that you have support to go into the emotion. And that's kind of through mindfulness training and other things. I think it's really important. There's actually a great book that we just read in our Palliative Care book club called 5 Lessons from the Dying. But one of the lessons, one is not waiting for tomorrow. Another is to go into the difficult emotion. So rather than going away or hiding from the grief, to go into the grief. And usually what we find, like if you take a difficult emotion like loss, is that loss is just the flip side of love. That you're feeling this deep loss because of the deep connection and love that you have. And if you're able to, stick with that and go into it, you can kind of come out from the other side a stronger person and a more peaceful person. So that's something that we definitely try to work with. So with spiritual well-being, and we talked about this a little bit earlier, is kind of making this distinction between real hope and false hope. And so things I would say with real hope is, real hope might be, getting your family together for a reunion. Real hope may be, going skydiving. Real hope may be getting your pain under control. False hope is going to Mexico and getting stem cells and I'm going to cure this, $40,000 later. False hope is, we're not going to talk about prognosis and we're going to, keep our head in the sand and hope that somebody comes up with a research cure in the next 3 years. Not that there's anything wrong with hoping for the best, but when we don't confront reality and we're not working with reality, we lose opportunities. And then 3 years goes by, there's not a cure, and we didn't get to take that trip, we didn't get to say goodbye to people, we didn't get to tell people how much we love them, and that's something that we can't come back. We spend a lot of time with resilience and coping. A little bit later, we'll have our website. But on our website, we have a whole, I think it's a 20-page packet now of different tools people can use for resilience. That includes pet therapy, that includes music, that includes meditation, aromatherapy, centering prayer. So there's a lot of ways that people can find peace and groundedness and resilience along this path. Help people to work with their identity. And ALS challenges identity in a number of ways. There's cosmetic aspects of ALS and how it changes the way that people look at us, the way people hear us. It challenges our identity in that a lot of people, their identity is based on what they're able to do and what their role is in the world, and when that's taken away, they can feel very lost. And again, working with connection, meaning and peace, and trying to find direct ways to help support those things. This is from the New Yorker, and I think it kind of shows some things about palliative care, but just some very simple things. So the first part of it, says enjoy your favorite foods, because at this point, why not? And it's grilled cheese and chocolate chip ice cream and molasses cake. The second thing says don't waste time doing stuff you hate, and it has a picture of a woman on the phone saying, "I don't like you, goodbye." And then the last slide is it says no heroic measures, and it shows her being comfortable at home, enjoying a glass of wine and reading a book. And to me that those are all like really strong principles of palliative care. Is that we want to try to support people with that, and that comes up sometimes too. Is that the nutritionist or the speech therapist says no food. You know, if you enjoy food and that's how you want to live your life and that's how you want to, you know, then do it. You know, most people don't actually die choking. And that's a fear that I think a lot of people with ALS have. People die from silent aspiration. It's pretty rare that they actually die from choking. And so if you like, you know, fried chicken or ice cream and you can, you know, handle it, then, you know, go ahead and do it. And then those are kind of some of the things that we work with goals of care. So when is the right time for hospice? So when I talk to people about hospice, I kind of talk to people about hospice in the opposite way that most people think about hospice. So I think when most people think about hospice, they start off with thinking, I'm going to die. You know, and secondly, what are the services? And then lastly, what are my goals? But I flip that on its head. And so the first thing that we do when we're thinking about hospice is what are your goals as a patient and as a family? So if your goals are, I don't want to go to the hospital anymore, I want to be as comfortable as possible, and I want to stay at home, then we can start thinking about hospice. And it doesn't matter how close you are to dying or not. You know, that would be when I would start thinking about hospice, would be when you would answer yes to those questions. And people can be, you know, and I have some patients who do want to die in the hospital and do want aggressive care right up until the end of life, and hospice may never be a good match for them. You know, so that's the first part of hospice, is what are your goals? Secondly, we talk about the extra layer of support that hospice could provide. So would you benefit from getting hospice? And there are some pluses and minuses to getting hospice. And then lastly, do you meet the prognostic criteria? And we could always almost build a case that people have a limited prognosis and we can get people into hospice when we need to. If people can't get into hospice, there's something called home palliative care that could provide some similar services. So the things that hospice does provide is it provides an alternative to calling 911. So you get 24/7 support. It provides a doctor and nurse practitioner who can come out and visit you in your home, who could provide aggressive care for symptoms like breathlessness, like pain, help you through any end-of-life situations. There's a social worker, there's CNAs, medical equipment. So there's a lot of perks that come with hospice. Hospice is paid for by Medicare, Medicaid, and all insurance companies. So it's not something that's going to cost you a lot out of pocket. That's a concern that a lot of patients have. So hospice can be a great benefit for a lot of people, and it's really underused in ALS. I think depending on the study, anywhere from less than 5% to maybe up to 20% of people you get hospice with ALS, and that's, I think, a shame. And out of that 20%, the average length of stay is from 3 to 2 weeks. This is something that could provide support for up to 6 months, and it's used from 3 to 2 weeks, and so we really like getting hospice started early rather than late.
Yeah, I would just echo just the importance of being proactive with it, just because, like when my dad was dying of cancer, and options weren't presented,
right.
And then we ended up calling 911, and then we found out the in-hospital hospice is only good for 6 days.
Right. Yeah.
So it's better to get it done like from the get-go.
Yeah, and then the hospice team knows you, they know your values, and then they can also help provide eyes and ears on the ground to help you, make decisions as things come up and be better prepared.
That would have been nice for me to be the daughter, not the nurse, going,
Yep,
oh,
absolutely.
my dad just fell, I think we need to take him to the hospital.
Yep.
So.
Yeah, and so like everything, I think that's one of the central messages from this talk today, is to do palliative care, do hospice, do it earlier rather than later. Yeah.
And I think it's important to keep in mind that you can stop.
Yep, you can.
It's not like you're stuck, like you're
right. Yeah, that's a great point.
Going down a one-way street to death. If you get better or have a...
Yeah, and we have people who graduated from hospice. I've had people who've been on hospice for 5 years. And there are times where people, maybe they have a pneumonia, they fall and they break their hip, and they decide, actually I want to go to the hospital now. And so people can come off of hospice. So that's a great point, is that you're not, committing yourself to a lifelong of hospice. Some of the red flags that I look for, and these are kind of some of the signposts that I would look for, and one of the things I want to make sure is that not everybody is going to experience any of these things. So sometimes when I give these presentations, I feel like people have what I would call the yets. It's like, oh, I don't have that yet, I don't have that yet. And just because it's up here does not mean you're going to have it.
You don't have to wait for it all to happen.
So, but things that would make me start to think about hospice is that if people are going in and out of the hospital frequently for pneumonias or bladder infections or falls, if they're having a lot of weight loss, having a lot of more problems with breathing or breathlessness, aspiration or choking, that they're having an accelerating loss of function. One of the myths I think around ALS is that it's like a straight line, and it's not a straight line. It tends to be flat and then kind of starts to accelerate. If people are withdrawing from activities and people and they have a loss of will to live, those would all be signs for me that we'd want to think about hospice. Medical aid in dying, and people here I assume are familiar with medical aid in dying at least to some degree, or also known as Proposition 106. It kind of comes up along this kind of umbrella of death with dignity. When I get a request from medical aid in dying, and I definitely have had a number from patients with ALS, the first thing that I want to know is what are people trying to accomplish? Is it because they're in pain currently? Is it because they have a fear of what their future self is going to experience? Are they feeling like they're a burden to their family? What's really driving the request? Because a lot of times, not all the time, but I think a lot of times when we do palliative care, and we do palliative care early, we can sometimes provide relief from the things that are driving people to make this request. That's not true all the time, but it is true a lot of the time that we can help people with that. So I want to know when would people use it. I've had a number of people who come in and they have a very specific date in mind. That I'm going to use it on October 22nd because that's my birthday, and I don't want to go through another cold season. Or it's like I just want to have it in my back pocket. If I'm ever in pain that can't be controlled without making me feel dopey, that's when I would want to use it. And a lot of people who have the prescription don't use it. So in Oregon and Washington, where they have a longer history of it, about half of people never fill their prescription. They just want to make sure that they have it in their back pocket. And it's also important that we talk about alternatives, and the main one being hospice. And so as we go over the eligibility, so to be eligible for the Medical Aid in Dying Act, you have to have a 6-month prognosis or less, which means that you also would be eligible for hospice. And so everybody that we see who wants medical aid in dying gets hospice automatically. Yeah.
If you refuse a G2,
Yep.
that gives you that window immediately, right?
If you it depends on where you are, but if you refuse a G-tube and you have kind of questionable nutritional status and your prognosis is 6 months or less, then absolutely. Yeah.
Okay, so.
Even with a G-tube, you could still be eligible for it.
Okay.
But yeah, if you refuse a G-tube and you're pretty clear that these are my goals and this is what I want to do, and if we agree that you're within your last 6 months of life, then you'd definitely be eligible. Yeah. One of the things that's tricky about the law, the way that's written, and there are people who are advocating for this, is that people have to be able to self-administer the prescription. And that can sometimes be tricky. Some of the ways that we've gotten around that is, some people, if they have a motorized wheelchair, that they can move the wheelchair so that it pushes a syringe into a feeding tube. If people are able to swallow, we can put it in their mouth and help them swallow. So there's ways that we can kind of get around it. But that is an issue in ALS where people can be quadriplegic and could have very limited physical ability to do it, even though mentally they have full capacity and they want to do it. And so that's kind of a bit of a civil rights question. It authorizes a physician to prescribe medical aid in dying medication. We can talk about what those are, and then it creates criminal penalties for tampering with that medication. Also important to know that it doesn't affect life insurance, it doesn't affect other insurances if you decide to use that. For people to use the end of life, so people have to be above age 18, so it's not something that children can use. People have to be able to make the decision and communicate it, which means that people have to have capacity. So that if people have significant dementia and confusion, then they're kind of out of the window for doing it. They have to have a terminal condition. Yeah.
But if you make your wishes known long before,
Yes.
that's.
Yeah. So when and there's kind of this window, and I have had some patients with dementia who have gone through with that. And with capacity, there's a couple things. One is that people can have capacity to make this decision, but not have the capacity to continue to run a bank. So it's really about capacity to make this specific decision. And then there is timing to it. I don't know if people have seen the movie Still Alice about a woman with dementia, but so she kind of missed her window of opportunity for it. And it presents, I think, one of the things that's really tricky about this with dementia is that people's quality of life can change in ways that they don't expect. And when people have dementia, their quality of life may be better than they thought it would be. And so it is pretty tricky about whether we want to make decisions for our future self and make sure that future self still has a voice to not go through with that decision if that's not something that they want in the future. So that gets to be a little bit tricky, but again, it comes down to having these discussions early and making sure that we're consistent and that your family knows what you want. And the actual process is that you need to make 2 requests, at least 15 days apart. So this is not something that you're like, oh man, I'm really in a lot of pain, I'm just going to go and get this prescription. It's a process. So yeah, it's 15 days apart, there has to be a written request, you have to see 2 different physicians, you have to have witnesses to the written request. And as far as the actual prescription goes, we've been using something called the DDMP mixture, which is digoxin, diazepam, morphine, and propranolol, which is $300 to $400. It's not covered by insurance. It's a lot cheaper than secobarbital, which was the old standby, which is now cost $2,000 to $3,000. And it's because the drug company raised their prices 1,000%. And drug
And it's
companies do
slower,
that.
isn't it?
They actually take about the same amount of time. For all the patients that we've done this with, they have gone into a coma typically within 15 to 30 minutes, but generally within an hour, and usually pass away within 1 to 2 hours.
The palliative nurse that spoke to me said it with the other one, the
Yeah.
second off,
Yeah.
4 to 6 hours. I said, what are you smoking?
Yeah. Now, even Technol is usually within the 1 to 2 hour window. There have been patients in both scenarios who have been in a coma for up to 18 to 24 hours. And that's another reason why we always want to have hospice involved, and we always want to have medical personnel there to make sure that people take the medicine, to make sure that they're not nauseous, that they don't throw up, and that the family knows what's going on and they have adequate care. So if they are in a coma, that they don't freak out and call 911 and end up compounding the tragedy. Yeah.
Do they lose consciousness
Yes.
immediately?
Pretty immediately, yeah. So
Oh, I was going to say,
within-
why don't they just put them under before they give them the shot?
No. The way it works is that you get medication for nausea first, and then in either mixture, part of the medications, you lose consciousness, and so you're in a deep sleep before you die. Yeah, and so as far as anyone knows that it's not a painful process. The families that have gone through with it and have reported back to me said that it was very peaceful. That it really met their family member's wish. And I think part of that is that we've had hospice involved, and we've been very careful about preparing people and making sure that we're well supported when they do that. I think sometimes people have this idyllic notion that they're going to go to their favorite park and take it on a park bench or something like that, and that's not a good idea. It's good to do medical personnel around and to make sure that everything's done right, and that if things aren't going well, that they'd be able to assist you. Oh, great. All right, so this one did show up.
Before we,
Yeah.
say you satisfy all those requirements,
Yes.
how soon can you get the concoction?
So once you, at that 15-day mark, if everything goes well, then I write the prescription, and then you usually can get within a day.
And how long can you keep it before you?
Well, so again, in terms of logistics, it's a powder that you drink, and we don't have people, have this powder on a medicine cabinet just waiting for when they want to use it. So we do, and again, this is because we have hospice involved. So if you reach a point where you're having a pain crisis or something like that, hospice can work immediately to give you what's called palliative sedation, to make sure that you're not uncomfortable, and that in the meantime, we can work on getting the prescription for you. And that usually takes 24 hours because for either prescription, it takes a pharmacist, a trained pharmacist, an hour to open up all the pills and capsules in order to do it. And because of the cost of the prescription and the danger of the prescription, we don't want people to have this out floating around and then have to dispose of it. So the typical thing is, if somebody is, coming to see us and, they have intractable suffering, they know they want to use it, then we can have things prepared, and at the end of that 15-day, give the prescription, and then, they can use it that day or the next day. Yeah.
Please could you speak a bit more on the 2 physicians that need to deem
Yeah.
you capable? What is that process like, and does that ever go wrong?
So the way it works, and at the university, we've made it our policy that anybody who makes a request, whether or not there are patients or not, has to see our team. Because we want to make sure that anybody making this request gets good palliative care. So one of the 2 physicians is going to be us. And we will either be the primary prescribing physician or we'll be the secondary confirming physician.
I'm sorry, do you need I thought you needed two physicians
do need two physicians.
certifying that you have
Yep.
less than 6 months.
That's right.
And then two, can it be the same physicians that are saying you are?
Yeah, that's the same,
able-
yeah, so you only need two physicians. So the way it most often works at the university is that one of your, say you're saying, Dr. Wickland is your ALS doctor. So your ALS doctor would be the primary or secondary physician, and then our team would be that. And both of us would work together and be in communication to evaluate your capacity. We want to make sure that it's not being driven by depression, that it's not really and we use the word medically aided dying to distinguish it from suicide. This is
Right.
not suicide. And if you think back to that slide about the mortality rate being 100%.
Well, what if a patient does suffer from depression? Is that?
That doesn't rule them out.
Eligible?
No.
No, then
Yeah.
where do you draw the line?
Yeah, and that can be tricky in some people, but as you can imagine, that people, whether they have cancer or ALS or other things, that about 30 to 40% of people who make this request do have depression. But what our job is we want to make sure that depression is not driving that decision. And so, the way we do that is that we talk to people, we try to understand what's driving it. And people with ALS, the most common reasons that people choose to go through medical aid in dying is not because of pain, it's not because of depression, it's because of loss of independence and kind of loss of what they would consider dignity. And those are things that no matter how hard we try in palliative care, that we can't change that. And so if somebody comes in and that's really what's driving it, and they also have depression and grief and other things, then we don't deny them that. The flip scenario would be, and we have seen this in sometimes, is that if somebody has really bad depression, they don't experience joy in anything, whatever, we will try to treat their depression first, and give them an antidepressant and give them a trial of it, because we don't want to, and there's actually a whole other ethical discussion about palliative care and medically aided dying for psychiatric disorders. And we can argue, both sides of it, and people with depression and schizophrenia and bipolar disorder, those are horrible illnesses as well, and they can be intractable, but as far as the law is written, it really has to be driven by a terminal illness and not depression. Yeah.
If an individual has seen a neurologist or their doctor has opted out of the
Yep.
participating in medical aid
Yeah.
dying, what are their options? I mean, I know that university participates, but
Yeah,
there are cases that don't. And so what?
Yeah, so if that is the case, and this has happened, that they would have to, if that's something that they really want, then they're kind of on their own to find physicians who will do that. And so, our group, we don't advertise that we do that, and that's not how we want to be known, and there's a lot of reasons why, we want to kind of be separate from that. But at the same time, we're open to having that discussion, and we're open to helping patients and families do that if that's what they want to do. And we do have, multiple physicians in our group, so our group can do it, even if your primary ALS doctor does not want to do that. Yeah.
What about your primary care physician? Just a
Your
general
primary care
practice?
physician could be involved if they want to. Yeah, the way the law is written, and I have a lot of problems with the way the law is written. The way the law is written is that there is no special training needed for the physicians who take part in this. They can write any prescription they want to. They don't need to use hospice. So there's a lot of things that, part of the reason that we've actually made a department policy for how we do this is that we really want to make sure that people have the best outcomes possible. But the way the law is written is that you could see, your primary care physician and a proctologist, for instance, and that they could fill out the paperwork and give you a prescription, whatever. And they may not be the best people in the world to do that. They may not address your palliative care issues. They may not explore your causes of suffering. They may not know much about hospice. And so we really do feel like it's important to have palliative care involved, but any MD or DO can do it. So yeah, this is my favorite television show growing up, so anytime I could put up a picture of Mr. T or a professional wrestler, I'll take that opportunity. So the A-team's quote is, if you have a problem, if no one else can help, and if you can find them, maybe you can hire the A-team. And so that's kind of what we see our team and our clinic as. It's really trying to help fill that gap. So we started our clinic in March of 2013, and as far as I know, we're actually the first clinic in the United States to offer these kinds of services. We've actually trained a number of other clinics, including Harvard, Michigan, we're working with the University of Florida, are coming to our clinic and visiting our clinic to look at our model and to bring it other places. And I think actually within the next 5 or 10 years that this is going to be more the norm than the exception that academic neurology has palliative care. When people come to see us, a first visit is usually 2 to 3 hours that people will meet with our whole team. For a time, we gave people a choice of who they would see, and a lot of people said, I don't want to see the chaplain. And it's unfortunate because the chaplain is one of the most helpful people on the team and is the highest rated, so we have everyone see our chaplain. You know, I think a lot of people have this idea that the chaplain is wearing a collar and he's going to read last rites and pray with them. That's not what our chaplain does. Our chaplain, helps people with anger, with guilt, with frustration, with challenges to their identity. He's one of the most amazing counselors I've ever worked with. And so he's just very, very talented when it comes to those kinds of things. We have a social worker, helping make sure that we, spend adequate time with the caregiver and with the family. And in our team, we can help with a single issue. Sometimes people want our help for, pain. Sometimes people may want to do co-management where they keep their normal neurologist and they get extra support for our team. And a lot of people decide that they really want our team to be their medical home. And we've purposely set up our clinic in a way that we could be kind of one-stop shopping to get all of your needs met in one place, and including hospice, and that I will stay on as the attending with hospice if and when you would need it. So there's myself, we have a nurse, a physician assistant, a social worker, or chaplain, and there's also an acupuncturist and a psychologist in the community that we work with a lot to help with some other issues. Things that we do is help people with transitions, and that could be hospice, could be assisted living, could be nursing home, providing resources for home health and community service, helping assess capacity and in decision making, particularly if there's a lot of contention within the family, helping people plan for the future and goals of care. I think one of the things that we do really well, and I think a lot of people are really done, are able to have straight conversations with people and give people the information that they need to make decisions in the future. So I'd say a lot of times people come into our clinic feeling very lost and confused, and come out feeling much clearer about what they need to do and what their priorities are. One of the important slides, actually, see if we could get up, is just our website, our scheduler's number, our clinic number, and my email. So if people are interested in contacting our clinic, asking me questions, other things like that, we can do it. And I think Mary will email it out to people or whatever. But if and when this ever works again, yeah, okay, cool. So I'll just leave this slide up. Last thing I was going to end with is just talking about a little bit about the future of medicine and about the other work that we do. So our section, and I'm actually spearheading an effort to create an international society for neuropalliative care. We've had 4 international meetings, and we're working on becoming an official nonprofit, is that we want to improve standards of care for people with ALS and other neurological illnesses. So if you think about the cancer center, if you go to the cancer center, you're going to see a social worker, you're going to see a nutritionist, you're going to get caregiver support, they're going to help you with hospice. If you have ALS or Parkinson's or Alzheimer's disease, you don't get that. And so that's kind of our #1 mission through our research, through our education, through our clinical care, through trying to set an example for other clinics, is that we really want to raise the bar really high for what patients and families that face these awful illnesses can expect. We are wrapping up a study right now showing, not surprisingly, probably to people in this room, that this model of care provides better patient quality of life and better caregiver quality of life than current standards of care for Parkinson's disease. We're doing a study that's community-based, and we have clinics across California, Wyoming, and Colorado, where we're teaching community neurologists how to do palliative care, and then we're using telemedicine to provide chaplain and social work and other support. And we have clinics in Salida and Grand Junction and in Wyoming, so that's another model of things that we're doing. And then we're also providing education. We're going to be meeting in Chicago to really get off the ground, making this a standard part of neurologist education. So that neurologists know how to give a diagnosis of ALS with compassion, that they know how to provide guidance for people, that they know how to, do better with pain management.
Well, Dr. Kluger, we want to thank you for a highly informative presentation, and we talked about about, some really difficult topics, with some care and sensitivities. So, yeah, let's give them another hand of applause.